Hi, I'm Tom Evans. I'm president of the Iowa Healthcare Collaborative, and today we're going to consider population health and the whole concept of healthcare transformation. How do we do better care, safer care at a lower cost? To transform care, there's a whole series of pillars, if you will, for transformation. That healthcare is completely going to be delivered completely differently than we do. We need to have different goals, different pillars for transformation, if you will. The first one is to not start with the provider community, but actually to start with the patient in the center. Are we doing patient-centered care? Are we engaging our patients effectively? Try to make sure that we're building the care that actually needs to be delivered. Point number one. Point number two, transparency, a commitment to the use of data to really understand where we are and move together where we need to be. Without that data, we don't know what we're doing, and it's very difficult for us to engage our patients effectively. The next piece for doing this, the next pillar for transformation would be a commitment to efficiency, a commitment to eliminating the waste and duplication in our current system and figuring out how we do this better with less. It's going to require a commitment in the development of skill sets in our communities to actually be able to do care better with every cycle of delivery. We have to have the skills of performance improvement mastered and then embedded in the way we do our care delivery. The last piece is frankly something that's kind of counterintuitive to the provider community. Today, we're all out kind of operating in silos, and it's going to take a commitment to collaboration, cooperation, participation as we all begin to operate in the healthcare system in a completely different way. It now becomes a team sport, and it's not just the healthcare providers that are on the team, but it's the entire community as well. I have an analogy that I've used with this transition. As we go from volume-based care to value-based care, it's not just doing a few things differently. It's an entirely different game. It's an entirely different sport. The volume-based system has done some wonderful things for us. It drives care to the hinterlands. It promotes access. But the value-based system is about efficiency and effectiveness. If you look at the volume-based system, a good analogy would be fishing. So everyone goes out every day and they get in their boat and they go at 7 in the morning. They fish as hard as they can all day, and at the end of the day, they come together at 3 o'clock. They see who caught the most fish, how big they were, and they see who wins the tournament. That's great. I'm in my boat. All I really need to worry about is where do I put my boat? And I wait for someone to jump on the line so that I can reel it in. My skill set is really kind of responsive or passive. It's not really a proactive strategy. The value-based delivery system will require us to be more proactive, more engaged. And we're going to have to think about things completely differently. As a matter of fact, the skills of the fishing tournament don't really help us very well with the value-based system. I liken it to moving from fishing to a different sport, to football. Football is a team sport. There are now, instead of just me in the boat, there are 11 people on the team. Each member of the team has a different job. They are specialized. They have very unique things that they all have to do. They're complementary. One person blocks for another. One person runs out while someone throws them the ball. There's a complementary relationship between them. They're coordinated. One guy goes first, one guy goes second. It requires us to have a bit of a choreography with how we deliver care. And our rewards, our reward system is linked. We only move down the field together. We only get penalized together. And frankly, we keep score together. The team only wins the game or loses the game together. One of the things that I think is most interesting to consider with regard to regional health improvement collaboratives is how do we actually engage and move our communities? How do we do this together? And there's a wonderful quote by W. Edwards Deming in the 60s that he described how when we can create systems of care or any kind of system, the system becomes self-preservationist. Once it's figured out what it is, it constantly works to set goals to prove its value and to be effective in its systemness. Deming said a very interesting point. He said, that's great in a static situation where we always just have kind of everything's the same. But in a time of transformation where you have different results required, the system itself may not be best equipped to achieve those. He basically said those systems create aims. He said, you know, in a time of transformation, systems don't really create aims. The aims create the systems. So the trick is, for a regional health improvement collaborative, in my mind, is what can we do when we convene a community and we all come together and decide we're here now in a local voice to figure out how we do what we do differently? How can we align? And one great way to align is if you can get everyone to understand and then commit to common goals, common aims, common visions of how we will be better. Everyone in that regional health improvement collaborative or in that region is committed to economic viability and to that local thing. So as you can create some local aims, it creates great buy-in and it creates great energy for moving your group forward. Everyone knows that diabetes is a significant national issue. We're you know, 2/3 of Americans are obese or overweight, and diabetes is epidemic at this point. One way that communities, one goal that communities can have might be to try to tackle something like that. But the challenge I would have would be not just identifying those diabetics that are in bad control. Instead, create kind of a community vision on what it means to be in good control. And then work, and I would call that at goal. And that can be a community effort to have everyone working to be at goal. For example, out of control, we usually measure as if their hemoglobin A1C is greater than 9. Imagine if we had a community commitment that everyone will be in control, measured by a whole series of metrics: A1C, blood pressure, cholesterol level, are they getting their eye exams, are they getting their foot exams? If they've had those 5 things, we check the box and we're done. That would be, that's called the D5. It's used in many states with regard to a commitment to having diabetics managed at goal. Imagine if our community made the commitment that we're going to have identified diabetics managed to such a state that they will not progress in their disease. Would that engage public health? Would that engage the employers? Would that contribute to presenteeism or absenteeism? There's a whole bunch of things. Everybody wins in a situation like that. So trying to identify a community goal and keep people focused on that can do a lot for the community's health. We have been working to do performance improvement for decades, and we have all the partners engaged, the payer, the purchaser, everybody's kind of there, but the provider community has been a bit of a bottleneck, if you will. I am a family physician. I understand the incentives of the volume-based healthcare system and how it incentivizes better care, and that's all great, but until we've had the macro legislation, the quality payment program, it's really been difficult to engage the physicians. I believe personally that the quality payment program is the linchpin that's going to make things now move. The incentives, the introduction of a physician-based incentive system that begins to not only incentivize providers to do better care and create healthier people. You know, it's interesting, we go from just fixing broken people to now keeping people from getting broken as we go forward. So this system now encourages the use of data, encourages the development of incentive programs to help physicians actually align with the rest of the healthcare community and move things forward. We're very pleased to be participating in the TCPI program as a PTN. I wish we could do more, but really what we're doing right now is we're moving from just an enrollment, helping physicians get engaged and learn about the quality payment program, to an engagement phase where they're really beginning to dissect their care processes on site and try to figure out how they can begin to do it better. We're now moving to the execution phase, where we're beginning to generate data, and more importantly, savings that are associated with that data. While we developed the science probably for the last 10 or 15 years, we've reached a very critical point. That is now being embedded into the reimbursement system, and now we're going to begin to create sustainability for doing value-based reimbursement. I think the quality payment program is in its infancy. It's just being ramped up. It will continue to expand and develop and mature over the next 10 to 15 years. But I think it's important to remember that the TCPI program, the PTNs, all of this stuff, it's basically, these are resources available to you to try to help, or available to physicians to try to help them figure out how they do performance improvement, how they embed that within their practices, and then with each care delivery cycle get better and better and better. theoretically, we all get to the point where we're not just thinking in a volume-based healthcare system, but we're trying to take advantage of those advanced payment methodologies, and we actually have a chance to really sing with regard to value-based care. The Affordable Care Act is only about who has insurance. It creates financing into the system, but the quality payment program, it's the law. There's no one arguing. There's no Democrat it's not a Democratic Republican thing with regard to, are we going to do the quality payment program? The Congress of the United States has basically committed, we're going to bend the cost of the federal government based on value. The whole concept of doing value-based reimbursement means that we're no longer just fixing broken people and only getting paid for that. We now have to figure out how we assume responsibility for the patient's total health, how we keep people from getting broken. I've seen several slides, several presentations that talk about where we can actually bend the cost curve. Where are the most, either the most costly situations or the opportunities where we have to really bend the cost curve. And it's interesting, if you look at a pie chart, about 20% of that pie chart is related to the acute care environment. The other 80% are related either to patient behaviors or social determinants of health. Do they have access to health care? Do they have access to housing? Do they have access to food? Do they have all these other things that are really outside of the healthcare environment? The reason that's so important is as we as providers begin to assume risk for managing populations, it's important for us to master the skills of helping the patients live a better life, not just fixing them when they're broken. And my big take-home message around that is the whole concept of person and family engagement. Are we configuring our care? Are we delivering our care? Are we engaging the context of the patient's life in a way that meaningfully helps them be healthy?